So any questions on anything from last week by any chance? Finish up the endo stuff, moving into talking about the OB stuff. Nothing at all. All right. So again, looking at, we talked about, the menstrual cycle. We talked about how estrogen and progesterone are normally being secreted throughout the period there, or throughout the 28-day period, so to speak. And again, which do you normally see kind of peak up first, estrogen or progesterone? Estrogen normally is going to peak up first, right? Because that's going to be in response to what? FSH and LH, right? You remember that LH surge? What does that normally kick off? Day 14, 12 to 14 or so, and that kicks off what? Ovulation, right? That's when you actually have release of the egg, and it can start traveling down the fallopian tubes there, right? And you get that corpus luteum. That is what is going to start to produce a lot of the additional estrogen, and then also progesterone, right? And again, kind of what I think about it when you are talking about, kind of proliferation of the endometrial tissue, I kind of think about estrogen kind of being the fertilizer, where it's kind of just promoting everything, kind of just growing. You ever like see if your yard or your lawn kind of grow kind of out of control? You're going to notice like it's not really even. Some parts of the grass are going to grow bigger than the others. It's kind of like that. And then the progesterone kind of comes through. It's a lawnmower, kind of makes everything nice and even, kind of evens things out there, right? So you're going to see that in the latter period. The latter 14 days there, and then once you have that withdrawal, right? So assuming you don't have any implantation, no conception actually occurs there, you're going to have that withdrawal of both estrogen and progesterone, and then what does that cause? The actual menses, right? So you slough off that endometrial tissue. The body says, hey, we didn't have any babies to tend to this time around. Let's try it again next time. And right, and the whole process is going to recycle itself. So anyway, so what are some cases where we're going to use estrogens for these patients here? We can use it for postmenopausal hormonal therapy, right? So in women who are not producing their own estrogen and progestin anymore, we can then replace that, right? So this is called HRT. If you ever see that, it's hormone replacement therapy. What are some of the symptoms you would expect to see in someone who's not producing their own estrogen and progesterone anymore? Okay, so what was the term for that? Dyspareunia, right? So painful sex. And why did they get that? Yeah, vaginal atrophy, vaginal dryness, right? Again, that's another part of the estrogen and progesterone. They're stimulating that tissue to be, to stimulate secretions and things like that. So you'll find that vaginal atrophy is going to be a big thing. In some women, that's their predominant symptom, right? And so if you can, just use something that's going to be able to treat just those local symptoms. We'll find there's certain vaginal products that are going to be better for that versus say taking something systemically. Okay. What other symptoms can you see with menopause? Hot flashes, right? So what are those? Sweating, feeling hot. Some people like to call them power surges. I think that's a nice, more positive spin on it. But yeah, so they get kind of hot, they get very uncomfortable. Is that kind of vasomotor sort of symptoms there? Now, again, do you think that's something you can treat locally, or you need to treat more systemically? That's a more systemic issue, right? Because it's kind of more body-wide there. Good. How about the bones? What's going to happen there? Osteoporosis, right? So you're going to see that for sure. Increased risk for fractures. So it's always going to be a big concern for those women there. And then also you worry about some of the cardiovascular changes, right? You worry about the lipid profile changes you can see there. Because again, remember, estrogen gets processed where? Where's it in the liver, right? And again, the liver is the main place where you're having a lot of cholesterol being maintained. And so if you lose that effect there, you can start to see changes where HDL starts to go down, LDL might start to go up, and so that can lead to more of a pro-atherosclerotic sort of a set point there. Okay, and again, there's a big initiative. They had this study that happened several years ago. This is before I actually got into pharmacy school, but it was called the Women's Health Initiative, and they were saying like, well, let's give all these women hormones. Let's see if it actually helps with their cardiovascular risk, right? What they actually found was there's no real big change there, right? So we don't give these for cardiovascular protection, and if anything, what do we say estrogens can cause? DVTs, clots, right? So again, that can actually cause cardiovascular issues as well, right? So again, if you die of PE or if you get a clot in one of your coronary vessels, things like that, those are going to be things you're thinking about with these drugs. So not typically we're going to give this for cardio protection. Anyway, and so again, when you're looking at this, you have to kind of consider what are the risks versus the benefits, right? So for instance, if I have someone who's a high risk of, say, breast cancer in their history, and it was, say, estrogen receptor positive, by giving that person estrogen, what can that cause? Breast cancer, right? Because again, we know it helps to stimulate the development of breast tissue. Same thing can happen as far as cancer goes, right? You have to consider the cardiovascular risk, the osteoporosis risk. All these different things are playing a role here, right? Deciding what is going to be best for your patient, whether they need systemic therapy, whether they need any therapy at all, transdermal, vaginal, etc. Right? Those are things we're looking at. Now, typically, what's the kind of the best dose we can use? the lowest dose possible, right? The least amount of drug we can give is always going to be beneficial. You just are looking for symptom management, right? And again, some of these things are long-term issues, like the osteoporosis, like you're going to be doing your DEXA scans and stuff like that to see how they're progressing. The lowest dose is going to be recommended there. Now, one big caveat here is that if your patient still has an intact uterus, you need to have estrogen and progestin. Why? You worry about the endometrial cancer risk. If you just have estrogen by itself, remember you get the grass is going to be growing all lopsided and stuff. You're going to find that you have unchecked growth there, and you're going to find the potential for hyperplasia and eventual cancer. Okay, not it's going to happen, but it could happen. By giving an estrogen and progesterone, you're going to keep those in check, and that's okay, right? Now, if a patient had a history of hysterectomy, you could give estrogen by itself, and it's not going to be a big issue there because they don't really have any endometrial tissue left to stimulate. Okay, so that's one of the big caveats you're going to see with that. So if you see someone who is, say, an older female patient and they're just taking an estrogen product by itself, chances are they probably have had a hysterectomy, right? They probably don't have any of that endometrial tissue left to really stimulate. Okay. Anyway, other things, we can use this specifically even if they're not having a lot of symptoms of menopause. You can see that these are good for the bone risk, right? So we know it's going to reduce risk for vertebral fractures, hip fractures, and things like that. Remember, though, that you also need to have what in addition to the hormones for bone health? Calcium and vitamin D, right? You have to have both of those. Remember how vitamin D gets activated? Where does it get activated before that? Remember, so it gets produced in the liver, or I'm sorry, in the skin, or in the diet, and then it will then get the first activation step in the liver, second in the kidneys. So think about organ function. Think about which one they actually need. That bad kidney function, what do they need? The active form, which is? Yeah, calcitriol, right? So again, you want to make sure you're thinking about these things, right? All this stuff kind of comes back. We're just talking about right before class, hyperlipidemia, right? Or drug classes for that stuff, right? All this stuff is going to come back, right? So you need to be able to jog your memory, make those little neuronal connections connect a little bit faster, right, by kind of re-challenging yourself with this stuff. Anyway, so those are the things that you want to consider. And again, if you're just having atrophic vaginitis, that dyspareunia, that vaginal irritation, itching, things like that, a topical product, and again, when I say topical, I don't mean like on the skin necessarily, but I mean topical in terms of being intravaginal, right? So again, you're not necessarily applying systemically. We also have transdermal products, right? So I want to make sure you kind of keep those delineations in mind. We have transdermal patches you can administer. The benefit of that is what? You skip the liver, right? You bypass that first pass effect, and so you don't have as much of those, the liver effects. You're going to see that, right? You worry about the cholestasis. You worry about the clotting factors. You'll still see some of it because it's still going to hit the liver, but it's not going to be as pronounced, right? If it takes something orally, the first place it's going to hit is the liver, right? And I mentioned what type of tissues like to absorb drug very easily. Very vascular, thin, right? So, thin mucous membranes, right? Just like the vagina, right? So you'll still see some systemic effects, right? There still is some risk for things like clots and things like that when you apply things intravaginally, or say, for instance, if you had an intrauterine device, if you're using that for contraception, there's still some systemic risk. It may not be as high, though, as with the oral products, okay? So just something to keep in mind. Okay, other things we can use it for, we can use this for ovulation suppression, especially if you have dysmenorrhea. We know that by stimulating that tissue, that causes the dysmenorrhea. By giving the estrogen, this can help to shut down that HPA axis, right? It's going to be able to go back and inhibit the hypothalamus and the anterior pituitary, so that way it's not releasing LH and FSH. That way you're not stimulating ovulation, you're not stimulating that pain associated with the menstrual cycle there. So that's something you can see there. Another thing could be, if you have excessive androgen secretion, you can actually help this by administering estrogens as well to get some more of those feminizing sort of effects, right? Because again, by inhibiting LH and FSH stimulation, that will also help to inhibit androgen production like testosterone and DHT, right? Okay, so what are some adverse effects? Well, uterine bleeding is going to be probably the most common thing you're going to run into, right? It's going to be abnormal bleeding, spotting, things like that, certainly outside of just when they're having their normal menses. And again, usually this can be, more of an issue of kind of just minorly problematic to the patient there. But there are cases where you have severe blood loss for some of these patients. We've had to have them come to the ER and manage that just because of the uterine bleeding was so significant. However, anytime you have or uterine bleeding, vaginal bleeding of an unknown cause, what do you got to rule out? Scary stuff, right? You got to rule out scary stuff like cancers and things like that. any pregnancy, right? I mean, I should always rule that out too. That can be pretty scary, right? Especially when you're not expecting it. But think about things like the cancers and things like that. Those are things you want to rule out as well whenever you have unexplained. And that, actually, that's going to be one of the contraindications of starting any of these estrogen products. If you have abnormal uterine bleeding, you don't know why, you got to find out first, right? You have to make sure you rule out scary stuff.
Are you talking about estrogen excess or like deficiency in this adverse effect?
This is going to be an adverse effect of actually giving the estrogen. Yeah, so either as a replacement or potentially if we're giving it for contraception sort of purposes there, right? And again, think about the difference in doses that you're going to be administering. If I'm using for replacement therapy, how's that dose compared to something if I'm using for a complete suppression of that HPA axis? It should be lower for replacement, right? Because I'm just trying to give them back what they're normally should be producing versus if I'm trying to shut the whole thing down, if I'm trying to inhibit ovulation or inhibit androgen production or whatever, that's going to be much higher doses, relatively speaking, okay? But keep in mind the relative potencies of things, because you may see that, for instance, 30 micrograms of ethinyl estradiol is going to be able to shut down the whole process, right, as you would see with an oral contraceptive versus, say, 0.6 milligrams of conjugated estrogens, right? You have to think about relative doses. That 0.6 milligrams is less potent, so you have to give a bigger dose of the drug in order to get the same sort of effect there. So don't just look at the doses and just assume that, okay, this one's for replacement, this one's for suppression. It's going to be dependent on the actual product itself. Okay, so it's kind of a little bit of a misnomer there. Anyway, again, you can use smallest doses of estrogen possible here, and you're going to find that typically you're going to be giving these estrogens cyclically, right? So again, usually giving them active drug for, say, 21 days out of the week, and you'll give them a week to have that withdrawal period, okay? So they can have the sloughing and then kind of get back to the normal cycle. And again, if they have so in the intact uterus, you need to administer that progesterone to make sure you don't have unchecked growth of that tissue and you don't have potentially risk for things like cancer developing. As I mentioned, cancer is going to be the big risk you're going to see that. There is certainly a known increased risk for breast cancer, especially with women who have a high-risk history. And so in those cases there, you're going to find that adding progestin doesn't really do anything for you, because progesterone doesn't really have as much of an effect on the breast tissue as it does, say, in the uterus. And so in some high-risk patients will actually use what we call a selective estrogen receptor modulator. Basically, that means it's going to be able to act like an agonist in certain tissues and an antagonist in other tissues. We'll talk about those a little bit later, but if you think about things like tamoxifen and raloxifene, those is where they're going to come up. We'll talk about that a little bit later. Endometrial carcinoma, as I mentioned, that's a risk, but we give progestin with that to prevent that. That's good. And then actually there's a rare cases adenocarcinoma in young women. This is actually linked to this is actually kind of interesting. It was linked to maternal use of a product called diethylstilbestrol. It's a hormonal product that the moms were using, and they actually detected it caused cancer in the women, the children who were born decades later. And it was actually kind of an interesting feat of using rigorous sort of research methods to actually determine, well, why do you have this grouping of women who are experiencing this type of cancer? What is the common link between that? And to get back to, oh, something the mom used decades ago, that's pretty hard to do, right? So again, the fact that we were able to pick that up, it's pretty good research methodology there, I would imagine. But anyway, that's something we don't use currently. Anyway, so other common adverse effects you're going to see: nausea, vomiting, you see breast tenderness. Why do you think you see that? Estrogen stimulates the tissue, right? Again, all of it goes back to the mechanism. All of this makes sense. Some things may not make as much sense, like hyperpigmentation, right? So you may see some increased melanin production due to effects of the estrogen in the skin. Again, some of this can be reversible. May take some time, but just keep in mind if they see a hyperpigmentation, may not be the best product. You need to switch to something else. Migraines. Now, if you remember, back when we were talking about neurology, what do we say is a potential treatment for menstrual-related headaches? Migraines. So you could use estrogens maybe to help prevent migraines in some women. In some women, it may actually cause migraines. Again, it's hard to know who's going to respond well. You got to try it out and see how they do, right? However, if you start a new patient, say, on oral contraceptives, and they say, oh man, I'm getting all these migraines, well, it could be linked back to the medication, right? So again, you may want to switch your product out or something like that. The cholestasis due to the liver effects, we know about that. Why do you think you see hypertension?
Doesn't it make you retain more fluid?
Yep, absolutely right. So remember, these are going to have some non-specific effects at other types of steroid receptors, right? So it can bleed over a little bit and have effects on the mineralocorticoid receptors, right? What's the main mineralocorticoid our body produces? Aldosterone, right? So again, you get a little bit of that bleed over effect, and that's why you end up seeing when the estrogen levels are starting to rise up throughout the month. That's why some women tend to put on a little bit of weight. A lot of that has to do with water weight due to the fact you're agonizing those receptors. You're holding on to more salt, and you hold on to more water, right? Wherever salt goes, water wants to follow.
So it's because that there's some, it's not the actual estrogen, it's just that there's bleed over into.
Well, so the estrogen is interacting with that aldosterone receptor, right? So you're going to see a little bit of cross-reactivity there, right? And you're going to see it with any kind of, glucocorticoids can do the same thing. That's why you see edema associated with things like prednisone and dexamethasone, things like that, mainly due to that kind of bleed over effect, right? It's not as specific as we'd like it to be, okay? But that's the main thing you're going to see there. But again, minimize it by using the lowest dose possible. Some contraindications, obviously any history of estrogen-dependent neoplasms, any kind of undiagnosed genital bleeding, again, rule out scary stuff, liver disease, thromboembolic disorders, heavy smokers. Why heavy smokers? Increases your risk of clotting, right? So again, these are all things you want to be considerate of. And again, anytime you see a young patient, young woman who comes in for a DVT or PE, you got to ask them, do you smoke and do you take oral contraceptives, right? Because again, one of those two are probably going to be present there. If they have no other history, of course, then you're going to do the rest of your workup for other, kind of thromboembolic, diseases, things like that. But those are usually the two big culprits in a lot of cases, especially the two together. Okay, getting to progestins, you're going to find that progesterone is going to be the common one that our body produces. It is the most common. Again, it's a precursor molecule too to a lot of other things. So for instance, estrogens, androgens, adrenocorticosteroids. And so what you're going to find is that a lot of progesterone products are actually going to have a lot of ancillary side effects related to that, right? So in some of the cases, you're going to find that some of these will agonize androgen receptors. What can that do in women? Hirsutism, voice deepening, right? Things like that. Are those usually good symptoms? Not really, right? So those are usually things that are going to be, and again, when you're deciding which oral contraceptive to give to a patient, oftentimes you're going to be dictating based off the progesterone what side effects you're actually getting from that, right? Because the ethinyl estradiol, which is common in most of those, you can modify the dose a little bit, but you're kind of stuck with that one. That's the most common estrogen you're going to find in those products. For the progesterone, that's where you're going to get much more leeway, and you'll find on that chart that I showed you there's things like levonorgestrel, there's things like drospirenone, there's a lot of different varieties, and they all have a different side effect profile based off their activity on androgen receptors, mineralocorticoid receptors, etc. Right? And so again, that's usually what you're going to find, and I'll give you some examples of that in just a little bit when we actually get into the different varieties you'll see there. And again, you're going to find that there's a high variability with these synthetic progestins that we're administering to our patients, right? So, and again, when I'm talking about these different receptor types, when you see AR, that just means androgen receptors, right? So that's where testosterone or DHT would be interacting. And then if I say mineralocorticoid receptors, that's MR. So again, that would cause what? The fluid gain, the fluid retention, the weight gain, right? Those are the big things you see with that. So, for instance, if you see something like levonorgestrel, this is high androgen receptor activity. So you'd expect it to have a high risk of causing things like hirsutism. Okay, so if you put a patient on this, does it mean they're always going to get it? No, but you could try it out and see if they say, oh man, I'm getting this weird, like, kind of mustache going on. You can say, okay, well, this may be not a good product for you. Let's go ahead and try switching out to something else, right? For instance, if you're looking at something, let's say here, you have a patient who's like, man, I get so bloated during my during my menstrual cycle. Like, man, I just want something to help with that. Well, what if you use something like drospirenone that has anti-MR activity, right? So actually, we can block some of those aldosterone receptors, and we have a little bit of weight loss associated with that. Things to think about, right? See PR, that just means progesterone receptor activity, right? So again, you can try one of these agents here first and see how they do. These are usually the older ones. These are ones that are probably going to be a little bit cheaper. And if those are not working, that's where you can try to switch out and try other agents here, like norgestimate or maybe drospirenone, things like that. Drospirenone, you always see like in Yaz or Yasmin. That's usually a good one to maybe recommend to a patient, maybe second line, if they have a bad time, say, taking something like levonorgestrel or something like that. Okay. So anyway, you'll find that these are also going to be metabolized in the liver as well, but you don't see the same sort of cholestasis sort of effects. You don't see the same thromboembolic sort of effects there. So just know you're not going to run into the same liver issues as you would with an estrogen there. And again, all the rest of it's going to get excreted in the urine. Now, again, the mechanism is going to be the exact same as the estrogens. We're going to be using them. You'll find that they get into the cell, they get to the nucleus, and there's going to be progesterone receptors. They're going to be interacting with the gene transcription, right? So again, these are the same activities as you would see for any estrogen, any androgen, anything like that. Okay. So what effects could you expect to see? They should have little effects on the lipids. That's mainly going to be the role of estrogens. You're going to see there as far as changing HDL and LDL levels there. Other things you can see, it can compete with aldosterone in the kidney, right? So again, either agonizing that receptor to cause more weight gain or more fluid retention, or it can maybe antagonize it, as we saw with drospirenone, cause some weight loss there. You see things like maturation and secretory changes in the endometrium. That's why I talked about the kind of the lawnmower sort of effect, kind of evening everything out in that tissue there. You're going to find by using these synthetic agents that have minimal androgenic activity, you're going to find that has lesser side effects and some that have more androgenic, as we'll see. Okay. So where we're going to use this, as I mentioned, this is going to be good for hormone replacement therapy, especially in women who still have an intact uterus. Again, you have to give that with the estrogen in order to get the benefit there of not worrying about the endometrial hyperplasia. And then usually more commonly, you're going to see this being used for long-term ovarian suppression. So I said you can't use, so say you have a young woman who needs contraception, right? So chemical contraception is one of these products here. Can you give estrogen by itself to suppress the HPA axis? No, why? Well, presumably, yeah, because the risk is that, well, if they're using for contraception, presumably they're at risk for getting pregnant. They probably still have an intact uterus, right? They can't use estrogen by itself because you worry about the hyperplasia, okay? So I'd use a combination, right? That's why the grand majority of those products you saw there were estrogen-progesterone combinations, okay? Could I use a progesterone by itself? 100%, yeah, absolutely you can use that. And so you actually will find some products. And as an example, if you ever hear like the Depot shot, right? And Depot just means what? It's like the Home Depot, right? You get a big supply of stuff all in one place, and it slowly leaches out over a long period of time, right? So that's why you use the Depot Provera, or this medroxyprogesterone. So you automatically know it's a progesterone product there. It's given intramuscularly, and you give it every 90 days, right? So what's the benefit of that? I don't have to worry about compliance. You don't have to worry about taking a pill every single day. You just know it's there, and you're good to go, right? Doesn't mean at day 91 it stops working. No, there's still some drug there, right? So you still see a little bit of lead over effect. Now, levels as they start to drop, you're much more likely to start to ovulate again. But again, you have a little bit more leeway there, right? So what kind of patient do you think it'd be good for?
Patients with like mental disabilities, like for instance, we had a girl who had, I don't know if it was cerebral palsy or something like that. Anyway, her mom was like, oh no, she's mentally now, I don't want to deal with that. So we would give her the shot.
Okay, yeah, so that'd be one way to do it, right? You think about people with mental health disorders who may be engaging in high-risk activities, where you want to make sure they're going to be compliant with their stuff, right? So think about severe bipolar disorder, schizophrenia, etc. People who are just busy and they don't want to think about taking a pill every single day. Like, there's a lot of good cases for this. There's some drawbacks to it, right? Though, so there's some negatives to using a progesterone-only drug versus using a combination. So we'll talk about what that is in just a second here. Yes, ma'am.
Does progestin follow the enterohepatic recirculation?
It's not as pronounced of an effect as you would see with the estrogen. That's the main thing you worry about with like antibiotics and things like that. This is not going to be as big of a concern for progesterone.
As far as giving this shot, let's say it's the first time they've given it, do they immediately have that effect, or do they have to do like a secondary birth control form for a little bit until it kicks in?
I'd probably use a backup for maybe a week or two, just to kind of give it time to really kind of seep in, get the levels up to actually suppress things. Again, the actual risk of getting pregnant with any one act of intercourse is pretty low, right? Because you got to make sure that you're actually having around ovulation and all those kind of things there. So if they didn't use protection, are they immediately going to get pregnant? Probably not, right? But it's, again, what's the downside of using a little bit of backup? Not much, right? So again, I would probably rather be safe than sorry in these cases there. Yes, ma'am.
So for patients that are heavy smokers, would you have them on a progesterone only?
That might be a better option. Yeah, if it's something where they're just like, I'm not ready to quit, that may be a better option for them, because you don't see the same coagulation effects, right? You definitely don't see the same. Now there is some risk, right? Because again, progesterones are a precursor to what? Estrogens, right? So again, you can still, even if you have a patient who's on an IUD or an intrauterine device that is purely progesterone only, there is still some risk for clots, right? So again, it's not nil, but it is one of those things where it's probably a little bit safer than using a combination with the estrogen.
I have a patient that was on this for a little while, and she actually had the opposite effect. She wouldn't stop kind of like breaking and like constipation, she would kind of go off it. So since this is what normally causes you to stop having periods a lot of times, what would have caused her to have off?
Yeah, so actually, if anything, you're going to see more bleeding with this, more abnormal bleeding, irregular bleeding with a progesterone-only product, mainly because of the fact that you don't really have the estrogen there to really kind of stimulate the tissue, so it's kind of out of balance a little bit, right? So again, those changes are not going to be, because the progesterone is still going back and inhibiting the whole process, right? Because you still don't have the FSH and the LH stimulating estrogen production, so you're kind of having progesterone trying to like stimulate this tissue, but you don't really have the estrogen part of it too, and that leads to that irregular bleeding, right? I'm sure there's much more detailed mechanism there with that, but that is certainly something you're going to expect to see is more abnormal bleeding with a progesterone-only product. Okay, so that's expected, right? Again, some people get a little bit better with time, and that's frequently, and one of the things I'll talk about a little bit later, is that typically when you're recommending an oral contraceptive product or any kind of contraceptive product to a patient, give them 3 months worth, right, at least to start out with. And that way you're going to see how they respond to it. They may have a bad first cycle, and then their body kind of get used to having that hormone around, and then it'll get the symptoms will get better, right? So that's why I usually give them 3 months worth, and they still hate it by the end of it, and then you can maybe switch them out to something else. Yeah, so again, that's just maybe just a bad product for that patient there. And again, this is one of those things where like every single person's a little different. Like it's hard to guess who's gonna. You may find like, hey, this one drug is like really good for like 9 times out of 10, 9 patients out of 10. But there's that one oddball that's gonna just not respond as how you would expect, right? Yes, sir.
So is that why? Because like the normal pills, like the last week is like a sugar pill, right?
Yeah, just placebo.
So is that to try to help have like normal periods?
That's precisely why you do it, right? So again, you're taking 3 weeks of active drug, and then that last week is going to be just placebo pills, right? You still want to make sure you have that habit of taking something every day, but that allows for that withdrawal of hormone, so you have the normal withdrawal bleeding, and then you have the cycle restart itself, right? You never ovulate, but you still have the withdrawal bleeding that goes along with that. So, as mentioned, there's going to be some negatives to this. So imagine, say, for instance, you were a young professional, young woman, right, and you wanted to go to PA school, and you're like, I want to get pregnant the second I get out of PA school. As soon as I get my degree, I want to get pregnant. Some people have plans like that, right? Or they say, hey, I want to go ahead and, get pregnant at a specific time. This is not a good product for that, right? And why do you think that is? It takes a long time, right? The drug is still sitting there, and the muscle's still kind of slowly seeping out. So you have a prolonged return to ovulation, right? So again, one of those things where, and again, some people like to schedule out everything in their life to a T. This is not a good drug for them, right? Because you're going to have that prolonged return to ovulation is going to be an issue there. You have this prolonged amenorrhea, which could be a concern as well. Because again, if you're amenorrheic, what are you concerned about? Might be pregnant, right? So again, this is one of those things where you have to be considerate of that as well. Again, irregular is really the key term here as far as the bleeding goes. Maybe a little bit increase, maybe decrease, depends on the patient how they're responding there. Okay, so yeah, as I mentioned, near future pregnancies, this is not a good product for that. Okay. However, if you want to make sure you have insured compliance, great drug for that purpose. Other things you can see, as I mentioned, increasing the blood pressure. That makes sense based off of the mineralocorticoid effects there. The androgenic effects. While progesterones don't directly themselves affect the cholesterol levels, you may find the androgenic effects may have a small effect to lower HDL a little bit. So that could be something notable if you had a patient with low HDL to begin with. Right? So, anyway, so getting specifically in. Oh, yes, ma'am.
One question. Is it bad if you're on like depo or anything like that, or if you're on like IUD and not having a period? A lot of them, you're supposed to lose your period after a while. Is that bad? So like not having a period for a long time?
Not necessarily. It's one of those things where as long as it's the progesterone that's keeping things sort of in check, right? You don't have like unchecked estrogen causing that hyperplasia, then you're kind of good to go, right? Because you can have things like seasonique where you only have 1 period a year, right? You can have IUDs that are in place for 5 years, longer in some cases there. So I'm not aware of any sort of negative effects of not having a period for that long a period of time, so to speak. But yeah, that's as far as I know, it's totally fine. Yes, ma'am. Probably due to the fact that progesterone is kind of inhibiting your body's natural ability to produce estrogen, right? So you could have long-term effects there where you'd say, well, let's try for a prolonged period of time, but then take you off of it for a while, try to get the estrogen effect sort of back there, right? Because these are young women, so you're not necessarily as worried about them developing osteoporosis as you would say someone who's a little bit older. Like you're not usually giving a depot shot to someone who's like postmenopausal, right? Because that's not really the use case for it. So those patients tend to be at the bigger risk for having the osteoporosis anyway. But yeah, that's a legitimate concern potentially. Anyway, so let's get into the specifics of hormone replacement therapy. Again, what are the FDA-approved indications, right? Because again, these hormones, they are still dangerous, right? They're still could be potentially deadly in the wrong sort of patient here. So it's important to know how to use these effectively. So looking at use for hormone replacement therapy specifically, so this is women who are not producing their own estrogen and progesterone normally. You're going to find this is good for treatment of those vasomotor symptoms, right? So they have those hot flashes, those power surges. This can help to manage those, right? We're going to need more of the systemic sort of effects there. These are good for treating vulvar and vaginal atrophy. That's that dryness, that dyspareunia that comes around with that. And then also for prevention of postmenopausal osteoporosis. And we know why it does all these things already based off what we talked about previously, right? So, as I mentioned with the estrogen-progestin therapy, this is best for patients who have not had a hysterectomy, so they still have an intact uterus. They need that combination. Right? I mentioned why that is. And again, for these women, you may find that they will be on estrogen progestin products every single day. I'm not really as worried about them having a withdrawal period. They can be on active drug all the time, and it's not going to be an issue for them. Some people still like to have that normal sort of cycle, though, and so you may find that where they'll have some products where they're getting estrogen maybe days 1 through 25, and then a progestin on the last 10 to 14 days, and they're drug-free for, say, a 4 to 5 day period at the end there, right? So you still have a little bit of that withdrawal bleeding that can occur along with that if that is what their preference is. And again, there's not necessarily one benefit to one over the other, right? A lot of it is based on patient preference. However, you were to talk to an OB GYN person who does this day in and day out, they may have different thoughts on it, but again, to my knowledge, it doesn't really make a huge amount of difference in the long run, right? Patient preference is really the big thing. As I mentioned, with estrogen, you can, again, either use it continuous or in a cyclic sort of manner, kind of what we mentioned above there. You're just missing the progesterone, but it's only going to be for patients who've had a hysterectomy. And what you're going to find is that typically you could use a low-dose contraceptive, right? You could use something designed to prevent pregnancy, but those typically is kind of overkill, right? You're going to get way too much estrogen, the fact that you don't really need. We're just looking to replace what we are the patient's missing because they're not producing it themselves anymore. So again, usually 4 to 6 times as much estrogen activity in those oral contraceptives is too much, right? You're more likely to run into those liver effects, the breast cancer effects, the the effects on the liver, etc. Like, so those are things you have to consider. Now, I mentioned we have a few different dosage forms here. We have oral, which obviously undergoes first pass metabolism, so it's most likely to have the hepatic effects. You're worried about clotting, you're worried about the cholestasis, things like that. Transdermal is going to be preferential for maybe women with a history of, say, increased triglycerides or risk for VTE, things like that, because, again, you bypass that first pass effect. Some of it's still going to get metabolized in the liver, right, eventually, but it's not going to be all of it kind of going through the liver at one time like you see in the oral dosage form. And then intravaginal is going to be preferred for just vaginal symptoms only, okay? So they really just have that kind of that dyspareunia, they just notice that vaginal dryness, but they don't really get the vasomotor symptoms. Nothing else is really going on. Just use an intravaginal product. It's going to be totally fine. We'll go through some of those here in just a minute just so you can see what that looks like. And again, things like vaginal tablets or the rings I'll show you have minimal vaginal absorption. They're kind of designed to try to just have local effects without trying to get a whole lot of the drug absorbed systemically. So you don't have to memorize these lists here. I just want to give you an idea of the different products that you're going to run into or the different products that are available for these women and why you might choose one versus the other, right? Because that's the kind of test questions I like to ask is, okay, well, which one of these is going to be the best product for your patient, right? And it's not just a matter of recognizing the brand name. So obviously that's going to be estrogen for this many days and this, but to know like, okay, well, is this patient a good candidate for just estrogen by itself? Can they use a combination? Should they use just vaginal products? Should they use transdermal? These are things you want to be able to kind of parse out, okay? So kind of getting into it, look at some oral estrogen products. These are things we're going to see things like your conjugated estrogens, right? So these are things like your Premarin. Remember where we get Premarin from? Yeah, we get it from horses, of course, right? From a pregnant mare urine. Again, those are synthetic now, so you don't have to tell your patients that you're getting the horse pee, right? You tell them that yeah, it's synthetic nowadays. But again, look at the different dosage forms you're going to be seeing here. And again, this is milligrams per day that they're receiving. Again, there's a wide variety of doses because you want to use the lowest one that's going to be effective for them, right? So you can start off maybe at 0.3. That's still they're still having those vasomotor symptoms, kind of gradually increase and see how they're going to respond to it. Lower is better in these patients, okay? Again, there's always going to be a bunch of different ones. There's estrogens, there's estropatate, a lot of different varieties that are out there, right? Again, not one's going to be better than the other. It's just a matter of which ones they kind of respond well to, okay? Next, you have the transdermal estrogen products here. Some of these are just going to be a patch you can just apply. And again, they will have active drug used for, say, several days, maybe a week, potentially, depending on the patch there. You maybe do, like, some of these are going to be once a week, some are twice a week. And again, that allows for that bypassing of the first pass effect, right? You get past the liver, you're going to see less of those hepatic sort of stimulation you're going to see with an oral dosage form there, okay? You have transdermal gels, transdermal sprays you could also apply as well. Again, these because these specialized dosage forms, they tend to be a little more expensive, so just keep in mind that, think about insurance costs, think about things like that, which your patient can actually afford, is going to be playing a role there as well, right? A lot of these older patients tend to be on fixed income. Price may be a really big issue with them, right? So maybe an oral product is just better from a price sort of standpoint. You have a question?
No, you answered it.
Okay, perfect. the best kind of question, the ones I answer without even trying. Then we have some vaginal products here. So again, you can either have things like vaginal creams. Again, these are usually going to be, you'll have applicators. You actually are going to, I'll have a picture of it in just a second, but you'll actually fill up the applicator with the gel or the cream, and that, to the specified dose, you'll just insert that vaginally, and then there's kind of a plunger you just kind of press in, and that will administer the drug to the vagina, and that way it has, and again, it's going to be able to have good local effects. Some of it will still absorb and get systemic, but not nearly to the same degree as like a patch or an oral dosage form, right? Here, conjugated estrogen primer and vaginal cream. Again, most of this is going to be related specifically to the vaginal atrophic vaginitis, right? So the dyspareunia, vaginal dryness, itching, things like that. This is really the best effects you're going to be seeing for these products here. Then we have things like rings you can administer. So these are things like E-string. These are just specific dosage forms. They basically are kind of a rubber plastic sort of ring that you can apply intravaginally. The drug is, so to speak, impregnated in it, right? So you have the drug that will slowly leach out of the ring, and then will have its local effects right there, okay? Now, what do you think happens if the ring falls out? Put it right back in. Yeah, there's no problems there. But again, if the patient really has it there and they're like, oh, I'm not really liking it, they can just take it out, and guess what? The drug's gone, right? These are not things that have to be administered by the provider. That'll be different than when we talk about intrauterine devices. Those need to be put in by the actual provider themselves, because it actually gets all the way in the uterus. Not necessarily. I don't know if there's any specific infections that are more at risk for. Obviously, you're going to have them educated on washing your hands, etc. Because anytime you're manipulating the vagina, you can see introduction of bacteria. So I would definitely recommend keeping things cleanly. But I don't know if there's going to be any particular increased risk for infection over anything else. Yeah.
Is that like the NuvaRing?
The NuvaRing is a different product, but yeah, it's kind of a similar concept. We'll look at that in just a minute there. But that's one's used more for oral contraception, or not oral, but for contraception.
Question, but where would you spray the transdermal?
Where would I do what?
Where would you spray it?
Oh, the spray can really be, as far as I know, it's anywhere. I don't know if there's any specific areas where they mention one or the other. That's something you can actually look up in the dosage or the lexicon or something, and it would tell you if there's any particular areas they want you to administer. Again, think about things like we talked about if you put it into areas of more thin skin, you're going to see better absorption there. If you put it in areas of occlusion, you're going to see more absorption there. So those are little things to consider. I haven't seen the more often than not, I see the topical creams, and I see the patches being used more than anything else. Yeah, I haven't seen the sprays ever used clinically, but again, I don't work in that realm very often, so I don't see it as much. Yeah. Even a vaginal tablet, again, this can be applied intravaginally. Again, it'll just stay there, leach that drug out over a period of time. This one would be just 1 tablet per day. And again, and this one actually is interesting. It actually has kind of an initial kind of a loading dose sort of dosing strategy where you use 1 tablet per day for 2 weeks, and then you use 1 tablet twice a week, right? So again, kind of a bigger dose initially to try to kind of get things, get that tissue beefed up from the estrogen effects, and then just have one twice a week at that point, right, for more maintenance sort of dosing there. Okay. So here's an example of what the permanent vaginal cream looks like. Here's the applicator here. Again, what would be good education points? Clean your stuff out, right? Make sure you're actually washing it appropriately, get all that drug off there, any kind of secretions or anything like that. Clean it up, right? So again, if you're not washing your hands, you're not keeping things clean, that's where you're running the risk of things like UTIs and vaginal infections, etc. Those are things you want to be careful of. Here's an example of the E-string, right? This can actually just be applied right around the cervix. It'll just kind of fit right around there, and then they're good to go for the most part. They usually have no problem staying in. Some patients, if they fall out, they can just put it right back in. That's no problem.
So do these topical estrogens, they not have as much of a risk of breast cancer as if taking it orally?
That is the thought, right? Because again, well, the breast cancer may not be as big of an issue, right? So the liver effects definitely you're going to be bypassing some of that. The breast cancer risk may not see much change, right? Because again, you're still getting it systemically. Certainly with the vaginal products, you'd probably see less absorption than something like a patch is designed to try to get those levels up, right? Because like a patch would be better for like vasomotor symptoms, more systemic than something like the E-ring, right? So I would definitely say if you still have a high-risk history, it's probably not going to be a good product for you, right? That's where something like tamoxifen or raloxifene, a SERM is going to be a better option there.
Okay, so like women who are still smoking, who have cardiovascular issues.
Right, so the smoking cardiovascular issues come about from the liver problems, right? Come about from the stimulating liver production of clotting factors and things like that. Right? So again, the breast cancer risk is more directly due to the estrogen interacting with the breast tissue itself, directly stimulating that hyperplasia versus stimulating the liver. right? Yeah, so keep those in mind, and the difference in mind there. But that's a good question, right? You want to keep those things delineated and wonder, okay, well, which dosage forms are going to help me with which symptoms, right? Which side effects? A very good point there. Okay, and then those are just purely estrogen-based products. Here we have some estrogen-progesterone-based products here. Again, it's not really so important you memorize every single different dosage form, but just look at how the dosages are going to be administered, right? They can either be continuous, right, where you can be doing the same tablets every single day throughout the month. There's no withdrawal period there, versus some of these are going to be more cyclic, where you only have estrogen during the first 2 weeks, and then you add on the progestin, right? That you consider it to be more natural, because that's what your body would normally be producing, where if you were still having your ovaries actually still producing the estrogen, right? So again, some people like the things that are more natural. Doesn't really make a whole hill of being differences. Some people may have better side effect profiles though on one versus the other, right? So again, it all comes back to patient preference. The big points to note here. Just note sometimes you may see changing doses of different products as they go on. Sometimes you may see the estrogen dose start to climb, maybe between week 1 to week 2, and that makes sense if you go back to that graph looking at how the estrogen levels would change over the period of time, right? But typically, if you're going to not do estrogen and progesterone at the same dose every single day, usually you're going to find the progesterone get added on in the second 2-week period. And that makes sense because that's when ovulation would occur. That's when progesterone would normally start to peak up in production. Okay. Again, here's some oral intermittent products here. This would be things where you do estrogen by itself for 3 days, and then do estrogen and progesterone for 3 days. This would be repeated continuously. So again, if there's any particular benefit, I'm not aware of it, but again, some people may respond better to that than others. Here's a transdermal product that are available. It's a combination. Now again, who needs a combination of estrogen and progesterone? If you still have a uterus, right? So if you still have any endometrial tissue left, you need to have the combination there. Good. And again, progesterone by itself, this is where something like medroxyprogesterone acetate, so we get the Provera, like Depo-Provera, could be a good option for those patients there, right? This is the oral form of the medroxyprogesterone. You see the medroxyprogesterone acetate, usually going to be the injectable form. That's going to be the Depo-Provera. It's the long-acting form. All right, any questions from the first half? Anything? Shh. Yes, ma'am. Yeah.
On these estrogen replacement or progesterone, is there a thin layer of endometrium still there that just doesn't slough off? Like,
Is it which type of products?
Or just progesterone, estrogen.
Yeah.
Like, is there still an endometrium?
Yeah, there's still tissue there, right?
Doesn't slough off? Like,
Yeah, you're still gonna have some residual. To my knowledge, yeah, you're still gonna. It's not like you like lose the entire uterus, right? Like there's still tissue there. It's just a matter of what's being stimulated or not, right? See, all the gentlemen are finally joining us. Thank you for your. I thought I scared you off with all this hormone talk. But yeah, so yeah, there's still some tissue there, right? So you don't necessarily get rid of everything. It's just usually like what has been stimulated during that month-long period, right? So kind of what you've been growing during that period will get removed, right? So anyway, so there are other things you could try, right? So perhaps if someone has a really high-risk breast cancer history and they don't want to go on hormone replacement therapy, there are other options here, right? So there are things we can use for the vasomotor symptoms, and these are things we've covered before, right? So actually anticonvulsants can actually help out with this. Antidepressants can help out with this, right? Full mechanism kind of makes some sense when you think about it. So when you think about the vasomotor symptoms, we mentioned what is that like? What are the symptoms you get there? You get the hot flashes, you get hot, you get sweaty, like, what does that sound, what kind of response does that sound like? Sympathetic, right? It sounds almost like a fight or flight sort of response. Well, if I could give something and try to tamp that down a little bit, that can help to kind of get that under control, right? So that's why something like clonidine makes good sense. So what does clonidine do? It's an alpha-2 agonist, so it shuts down sympathetic output, right? Just like I would use that for, say, abstinence syndrome in a neonate who's withdrawing from opioids. Their sympathetic nervous system is going crazy. I give them clonidine. It helps chill them out. Same thing can happen here a little bit, right? Things like antidepressants like SSRIs and venlafaxine, they can help out with kind of re-regulating things like serotonin and norepinephrine release to try to get things re-regulated so that way you may not have the severe symptoms. Now, again, some patients will respond better to these than others. Some patients may not respond very well. They may still need the hormonal therapy, but again, it's a useful option if you don't want them to necessarily need or want to be on hormonal therapy. Okay, so moving into the oral contraceptives themselves, we already talked about these. Again, when you're looking at and again, these are always combination products, right? Because again, presumably these are for contraception prevention, so these are presumably women who still have an intact uterus. They always see combo, unless it's progesterone only. But usually they'll either be in a monophasic, a biphasic, or a triphasic sort of formulation, right? And it just means is when do you have changes in dose of the different products there, right? And if you look at that chart, you can find that the progesterone may be the thing that changes. You may find the estrogen is the thing that changes, or it could be both, right? If nothing changes, you receive the same dose the entire 21-day period, you're going to find that it is considered to be a monophasic. If you just have one change, usually around the 14-day mark, that's a biphasic, and if you have 3 changes, one every week, then that would be a triphasic. All right, so that's kind of what we're referring to. And usually the brand name will kind of give it away a little bit. So if you see something like orthotricycline, it's tricyclic, right? It kind of makes sense there, right? Or if you say orthotricycline low, oftentimes that will delineate kind of the estrogen dose that you're receiving there. So look at the brand names and kind of look to see how it affects the doses of the progesterone and the estrogen. You'll kind of see some a little bit of common sense there as far as how the brand name. Now some things are not going to make sense at all. See something like, you know, Yaz. That doesn't really tell me much, right? But some of them are nice and they'll at least give you a little bit of a clue as far as what you're actually getting here, right? And as I mentioned, you could receive progestin-only therapy. We already talked about the depot shot as being an option there. You can also get what they call the mini pill, which is just going to be progesterone-only pills that they're going to be taking there. Okay, so those are different options you have available to you. Now, as I mentioned, these are going to be much bigger doses, relatively speaking, than what we use for hormonal replacement therapy. Because again, we want to shut the whole system down. The whole goal here is to try to prevent ovulation. And so by shutting down production of FSH and LH, by feeding back and showing the hypothalamus and the anterior pituitary, hey, we have enough estrogen and progesterone around, we don't got to produce this ourselves, you're going to find that you'll drop the levels of FSH and LH. You're going to see that you don't have the same ovulation occurring there. Thus, you should not be able to get pregnant because you're not releasing that ovum to actually get implanted. And so other things you can find is that by giving these products here, it also makes the the reproductive tract less favorable to the implantation and I guess the hospitability of, I don't know if that's the word, hospitality, I guess you say, to the sperm, right? Basically makes it less of a good environment for it to kind of thrive there. So you see things like changes in cervical mucus. You're going to find that you have changes in the uterine endometrium. The motility and secretion are going to be decreased there. All these things are going to make it less likely for the actual the conception to actually occur there, right? So you can't conceive, can't implant the ovum and the sperm into the uterine tissues. You can't form the placenta. Nothing happens, right? And so those are the things that happen there. And even when you have something like just an intrauterine device that is just releasing progesterone, you're still not necessarily having as big of a suppression on the HPA axis. However, you are making it very unhospitable to the actual semen to actually make it to the egg in order to actually implant it, right?
Is that cervical plug?
That is part of it, right? So again, it's part of that cervical mucus that can form there, that can form that plug. You usually see that with pregnancies and things like that. It's like when they lose the plug, you know, it's usually when you see the water break and all that kind of good stuff and all that.
Do you see that in women on pills?
I don't know if you can necessarily get the same sort of plug. That's a good question. It's outside of my realm. I'm not sure. Yeah, it's a good question. Yeah, I don't know if you get the same sort of plug as you would like with actual pregnancy that occurs there, right? Because you're trying to hold everything in versus, yeah, I don't know, probably not. Anyway, so those are the big things you're going to see. Notice that the progestins alone don't always inhibit ovulation, but they definitely make it, the cervical changes, the uterine changes make it so, again, it makes it very unlikely to have implantation and actual pregnancy occur. Okay. Now looking at the physiologic effects, you're going to find with the ovaries, you're going to find decreased ovarian function. Again, they tend to be smaller during therapy. That kind of makes sense, right? Why should they be smaller? Well, they're not being stimulated by FSH and LH, right? Remember what happened if I give androgens, like testosterone, to male patients? What atrophies? The testicles atrophy, right? Because again, they're not being stimulated by LH and FSH. Same thing happened to the ovaries, right? They're not going to be stimulated. So they may atrophy a little bit. May not be as obviously as apparent as you would see like in a male patient, but they certainly will atrophy to some degree. And again, note here that as soon as you take away the oral contraceptive, things will get back to the normal cycle again, right? You're going to find that typically, you know, about 75% of women are going to start to ovulate back on the first cycle. 97% by the third. Some women, though, are going to have a delayed return to ovulation. That's just something we know is going to happen. But most people tend to get back on the normal cycle pretty quickly after they get off the contraceptives, right? So again, that's kind of a nice thing. And this is why it's better to use a combination product. If you have someone who say wanted to get pregnant at a specific time, right? If they say, hey, you know what, I just got married and I want to have my honeymoon, and then we want to get pregnant, right? So then you'll have that return to ovulation much more readily than if you were on, say, something like a long-acting progesterone. Okay, so again, that's one benefit there. We'll talk about some other issues as well. Again, you're going to find that with the uterus, you're going to have thicker, less copious mucus, and again, that makes it more difficult for the sperm to travel in order to implant with the egg. So again, that's other changes that occur to make it less hospitable to the sperm there. With the breast tissue, you're going to find enlargement. That makes sense because, again, you're going to be finding that estrogen is going to be stimulating hyperplasia of that tissue there. Again, that can lead to some of that tenderness we talked about as far as the adverse effects go. Also can suppress things like lactation. Again, so that can be a problem, especially if they were actively trying to breastfeed, right? So that can be an issue. And then obviously the hematologic effects we talked about, right? Decrease in antithrombin 3, increase in your clotting factors, make you more risk for developing DVT and PE. Again, that's mainly going to be from the estrogen effects. Progesterone to some degree can cause that, but mainly it's the estrogen. And I'd also talked about the hyperpigmentation. Typically, if you have a darker complexion to begin with, or if you have a lot of ultraviolet ray exposure, again, we live in Florida, maybe not today, but most days it's pretty sunny. You may see a little bit more of that hyperpigmentation. And again, just know that that it can be reversible, but it depends on the degree, and it takes a while for that to reverse. Other things you can find is that due to the androgen production from the progesterone they're receiving, you can see potentially some increases in acne. However, what do you sometimes give patients to help treat their acne? Or contraceptives, right? So again, it all depends on the person. Some people are going to have worsened effects, worsened acne. Some people are going to have improvements in their acne. It's all going to be very dependent on the person. Okay, so obviously what are our clinical uses here? The biggest thing is going to be contraception. Now again, if you take it with perfect use, meaning you take it at the same time every single day, just like you're supposed to, is it perfect drug? Does it always prevent pregnancy? No, right? There's always going to be some degree of risk of it failing. Even if you were to have extremely perfect use, you're going to find that with the combination product, 5 to 12 pregnancies per 100 women years at risk. That's with typical use, right? So you're going to find that's with how people would normally take it. If everyone taking it perfectly, it'd be 0.5 to 1. So you have 0.5 to 1 pregnancies. If you had 100 women, you followed them for 1 year, you find maybe 1 pregnancy there with that risk. Normally, with typical use, right, some people forget doses, some people may take it at the same time of day, some people are getting antibiotics, some people, a lot of different things factoring in. You may find 5 to 12. Okay, so it still can happen, right? So it's still not a bad idea. Say, if you want to use backup, that's totally fine, right? Again, it's low risk proposition there. We'll talk about ways to get around some of the issues of things like if you miss a dose, things like that. We'll talk about strategies to get around that. But again, think about things like drug combinations that are going to increase the metabolism of these drugs and to drop your estrogen levels. Because as soon as you start to drop the estrogen levels, what can you have happen? You lose that suppression. LH and FSH are going to start to be produced again. You have ovulation. Okay, so think about things like enzyme inducers. Think about things like phenytoin. So they have a seizure disorder, and you're giving them phenytoin and their oral contraceptives. You can see increased metabolism of the estrogen. Levels drop. They could potentially get pregnant, right? Or think about things like, we talk about valproic acid, carbamazepine, a lot of those anticonvulsants. Remember what else was of note with those anticonvulsants, say if a patient got pregnant? Like, so, if you had a patient, a lot of them are teratogenic, right? So again, if you had something that would decrease the efficacy of your contraception, and they're also teratogenic, that can be pretty problematic, right? So again, that's why education is super, super important for these patients. Make sure they understand these are the risks, right? And if this fails, this is why you want to use backup, right? Maybe this is why you want to potentially use a different formulation in order to get around some of these issues here, okay? So again, if they're on enzyme inducer that affects the metabolism of estrogen, well, maybe a progesterone-only product is better for them, okay? These are things you want to consider. Again, anything is going to decrease that enterohepatic recycling of estrogen is also going to be playing a role here as well. So if I were giving them, say, a bile acid sequestrant like cholestyramine, right? If I were to give them antibiotics, right? See, bile acid sequestrants keep coming back up, right? Come back to haunt you. These are all things that are going to maybe interrupting that enterohepatic recirculation. Could also drop your levels. Could also lead to ovulation. Okay. Other thing, endometriosis can also be treated with oral contraceptive products. Again, you may find the estrogen by itself is not going to be enough to help to alleviate the pain. So that's why we use a combination of estrogen and progesterone there. Now, again, this makes sense why we would use this for endometriosis because, again, what's stimulating the endometrial tissue to grow? The estrogen coming about from that FSH and LH, right? So again, by suppressing that, it can help to kind of normalize things a little bit and help to decrease that. Okay, and again, to limit the adverse effects, which can actually make the pain worse, you want to use the lowest dose effective here, right? Okay, so adverse effects we mentioned before, nausea, vomiting, fairly common with these, mastalgia, breakthrough bleeding, edema. A lot of this is going to be related back to things like what progesterone they're receiving and what dose of the estrogen they're receiving as well here, right? Some people are going to have worsened migraines, Maybe just kind of minor headaches. We know that's going to happen. And be aware as well is that you may have failure to have withdrawal bleeding, right? Especially during that first 3-month period, you may find it's a little bit hit or miss as far as their bleeding schedule is going to be when they're first kind of getting used to it, right? And again, if you have failure to have withdrawal bleeding, say that first month, what are you going to think? You're pregnant, right? Or at least that's a concern, right? So yeah, maybe tell them, hey, with the first time, don't worry too much about it, right? As long as you're using it like you're supposed to. Maybe the second time, though, that's when maybe you have a little bit more concern there, right? You're going to get a pregnancy test, right? Anyway, and again, if it is problematic, if they're not having effective withdrawal bleeding, maybe you need to change the product out altogether, okay? These are things we're considering changing the progesterone, or maybe changing the dose of the estrogen. As I mentioned, more moderate sort of adverse effects, breakthrough bleeding, very common, especially with progestin-only products, right? Because again, you're not going to have the same sort of kind of uniform, stimulation of the endometrial tissue, so you're going to see more abnormal bleeding, especially with the progestin-only products. About 25% of women are probably going to experience that. And again, the lower the dose of the preparation, such as those mini pills I talked about, the more likely you are to see that. Okay. And typically what you're going to find, especially with biphasic and triphasic products, you may get the same total amount of hormone throughout the entire month, but by shifting it around to maybe putting more of the progesterone on the back end of the month, maybe more of the estrogen on the front end, are going to find you may have less breakthrough bleeding there, right? So we'll talk about some changes you can make a little bit later based off of that, but just know that is something that we're switching from a monophasic to a bi or triphasic may be able to help out some of those symptoms. Okay? And then weight gain, more common with the androgen-like products, more with the more mineral-like corticoid effects. That's mainly going to be an issue with the progestins for the most part. Okay, as I mentioned, increased pigmentation is something to be aware of. If you have vitamin B deficiency, this actually makes it worse. Make sure they're getting their prenatal vitamins. They'll always have the vitamin B in there. This is good. And then we talked about the acne as well. Again, if a progestin has more androgen receptor activity, you're more likely to see the acne develop there. So again, that's why you may want to try something with anti-androgen activity or lower androgen activity based off that table we were looking at before. Other things, hirsutism. Now again, why does that occur? Yes, the androgen activity can be ramped up either through the progesterone, right, or maybe the estrogen gets somewhat getting converted over into that. So just be aware of that. Urethral dilation, this can actually make bacteriuria a little bit more frequent because, again, they have those changes in the actual urethra there, something to note. Again, it's kind of the same effect you'd actually see in pregnancy as well, right? So, again, you can find that asymptomatic bacteriuria can happen to those women. It's usually due to those ureter changes there, or urethral changes, I should say. Again, things like amenorrhea, just be aware of that, especially if they're taking progestin-only products. These are other things to consider here as well. Oftentimes, women have a prolactinoma. That could also be something concomitant that could also be causing that amenorrhea to occur there. Why does that happen, do you think? Why does prolactin suppress? Why does it suppress that, though?
Because your body's, lactating, shouldn't be pregnant at that
Yeah,
time.
right. So again, if I'm trying to feed a little infant, right, I probably don't need to get pregnant again at that same moment, right? So again, that's why you would see that. And again, that's why you end up seeing things like PCOS, and they have prolactin playing a role there as well. Anyone remember what we give to treat a prolactinoma? Dopamine agonist, like bromocriptine, right? You can actually give that to help drop those prolactin levels. Because again, remember, if we give something like an antipsychotic that blocks dopamine, what does that cause? Galactorrhea, gynecomastia, right? Because of the prolactin effects. Remember, all this stuff is interlinked, right? Always go back to the mechanisms. You're going to have 90% of the stuff down, right? Anyway, again, the severe effects we're worried about, obviously, because again, this is more pronounced here because the doses are higher that we're giving because we're trying to suppress the whole function here. Venous thromboembolism, higher risk, we know it's going to happen. Now, if you come off of the oral contraceptives, what does your risk do? Stay up or does it go back down? It goes back down, yeah. So again, as soon as you come off of it, the risk is going to be decreasing as well because, again, your body's getting back to normal as far as what kind of estrogen amounts it's going to be producing itself, okay? And again, if you see a young lady come in with a PE, ask them about this, ask them about smoking because that's the most common things you're going to run into, okay? Now, again, if you're thinking about anticoagulation therapy, right, if you think about someone who has, say, kind of an inborn issue of hypercoagulability, they may have to be on anticoagulation for life, right? However, with someone like this, say you have a young lady who develops a PE secondary to oral contraceptive use, how long do you think they need to be anticoagulated for? Usually just 3 months, right? So you see a lot of patients end up being put on like an Eliquis or a Apixaban or something like that for, say, 3 months afterwards. But again, what are you also telling them to stop taking? The contraceptive, right? So again, this is where something like an intrauterine device is progesterone only, maybe I've been a better product for them. than using something with estrogen in it. Yeah. Anyway, MI can occur here as well. Again, this could be especially in patients who have that metabolic syndrome, obesity, hypertension, diabetes. Obviously, smoking is going to be increasing your risk as well. So again, this is going to be more kind of a long-term sort of effects you can see with that. Cerebrovascular disease, again, that makes sense based off what we're talking about with the clotting risk seen with that. And then the gastrointestinal effects we mentioned, cholestatic jaundice that can occur here. Again, that's due to the estrogen effects in the liver. More likely to see in those first 3 cycles. That's why we give 3 months at a time to make sure to see how they're responding to it. And then if they're doing well at that period, then you can give them the whole rest of the year if you want to, right? Now, some patients, you may find that their mood may worsen or may actually improve with hormonal therapy. Some patients with depression may actually have a little bit of a boost when they're on hormonal therapy. Some patients are going to have the opposite effect, right? This is kind of like the, the issue of acne, right? Some patients are going to help with, some patients are going to hurt them. And again, in this case here, if they have new onset depression and as a result of this, they probably want to get them off the products there, okay? And then we talked about the cancer risk. Just be aware of that, especially, overall the reduced risk of endometrial and ovarian cancer, and again that's progesterone sort of effect you're going to see with that, but you will have sort of a breast cancer risk appears not to be affected, but if anything you might see a little bit of an increase in risk there, okay? And again, it's only going to be while they're actually on the therapy. As soon as they come off of it, that effect's going to go away, so your risk should kind of go back relatively into normal at that point. Okay, so this is a good table going through the different progesterone products and sort of what sort of effects you're going to expect to see there, right? So again, they have estrogenic effects, progesteronal effects, they have androgenic effects here, right? So again, if they have something like hirsutism, you may want to take them off something like levonorgestrel and put them on something like drospirenone, right? It has no androgenic effects, right? Or anti-androgenic effects in some cases there, right? So just know what kind of side effects are associated with those things. Right, so the acne, the hirsutism is usually linked to the androgenic effects. The mineralic corticoid effects you're going to see is going to be more related to the progesteronal effects. Those are things you want to kind of key in on. Okay. Yes, sir. Mm-hmm. It's going to be kind of, for some patients it may be a little bit more pronounced than others, but it's kind of, probably shouldn't see a whole lot of change, right? So again, that's why for a lot of patients, if I hear like, they're on something like orthotricycline and or something that has levonorgestrel or norgestimate or something like that, they're not really doing all that well with it. Oftentimes they're like, I've tried Yaz before, because drospirenone tends to be pretty well tolerated progesterone from that effect. Again, if anything, they lose a little bit of weight because they have the anti-mineralic corticoid effects. Like some people tend to do pretty well with Yaz from those cases there.
Like a big thing against Yaz.
I'm not sure. I haven't seen anything recently. What have you heard?
Yeah.
I have to look it up. I don't know anything specific. But, yeah, they're like, oh, have you taken the drug ever? We can get you lots of money. Yeah, and again, always take those things with a grain of salt, right? Because again, you find things for Zofran, you'll find them for like drugs you're going to use like every single day the rest of your career. Again, it's all a matter of how you're using these drugs. Make sure you're screening for the appropriate patients. The one I think of Zofran because that's the last one I probably saw. But again, they're like, oh, did you get QT prolongation from Zofran? Like, well, yeah, we know it causes QT prolongation, but we know it's an exceedingly rare subset of patients who are actually going to have a clinical manifestation of that and are actually going to be problematic, right? And you know who to avoid. You know patients with prolonged QT. You know patients who have multiple drugs that prolong QT, to avoid them. Those are things, right? So as long as you're doing your due diligence and screen these patients and make sure you're not using them inappropriately, you're going to be fine, right? And document. Everything.
Doesn't have estrogen effect, doesn't have progesterone effect. How is it working as a birth control?
It still works. It's just you don't see the side effect profile, right? So this is really the side effects we're thinking about here when we're looking at this table. Mm-hmm. Yeah. Anyway, so again, look at the contraindications. This is really important, right? Who not to use these products in. Because again, if you had someone who is a heavy smoker, who had a history of hypercoagulability, you say, here, take this estrogen, and they have a PE and die, that's kind of on you, right? Because again, you didn't screen them effectively and look for those contraindications. So things you want to look for, any history of CV, cerebrovascular disease, thrombophlebitis, anything like that should be a high-risk patient to you, right? You should consider really strongly whether they need an estrogen-based product. They have an unknown cause of vaginal bleeding. Because again, you don't want to suppress that if the case is something like cancer that you need to actually evaluate and assess for, right? Estrogen-dependent tumors. That makes sense, right? You don't want to give them anything to activate that. Heart failure. Why do you think that would be a potential risk? Right, the fluid retention, right? The edema could be worse in there. That's one thing to consider. How about adolescents who haven't undergone epiphyseal closure? that will actually cause that closure to occur by giving them estrogens, right? Remember we talked about if you have primary hypogonadism, right? We'll give you whenever they should normally start their puberty. That's when we'll actually start to administer the estrogens there, because we know that closure is going to occur. We'll make sure they achieve their natural stature, right? So that makes sense there. If there are any kind of hepatic enzyme inducers, why would that be a problem? Drop the estrogen levels, increase your risk for pregnancy. Perfect. Antibacterials we mentioned, kind of, again, that's going to be one of those things where it's like, can I say that definitively, if I give you amoxicillin along with your oral contraceptives, you're going to get pregnant? No, but is it a problem to tell them, hey, maybe use some backup protection while you're on this? Probably, it's not going to be probably a big negative to them, right? And then obviously if they're pregnant, you don't want to give them more hormones because they're going to be producing their own anyway, right? Now, talking about progestin-only contraception, this is going to be good for patients who are not good candidates for estrogen only. However, you're going to find that if taken perfectly, it's going to be nearly as effective as using the combination. The problem is that when you miss a dose or you're not using it effectively, you're going to find that your margin of error is going to be a little bit bigger with this one, right? So again, it's really, really important to make sure they're taking it like they should, or use something like the depot shot, and that way you can ensure compliance from that standpoint. Okay. Also note you're going to have more abnormal bleeding. This typically decreases with time, but for some patients it's going to get worse, you know, as we mentioned, your acquaintance. And then you will have that delayed return to ovulation as well, right? We just know that's going to occur. Again, if you have a near future pregnancy plan, probably not going to be the best products for the patient. Okay, talking about postcoital contraceptives. So this is like your plan B. This is like your emergency contraception. Say if someone was a victim of sexual assault or anything like that, or any high risk activity where they say, hey, I probably want to take the morning after pill. This is what they're going to do, right? Now, do you need a prescription to get a plan B? No, you can actually go up to the pharmacist as long as you're over 18. You can get this yourself. You can still write a prescription for it, right? So that's not a problem, but patients do not need to have a prescription for this themselves. They can go and pick this up, right? Of course, there might be some people who have some moral grounds that they don't want to dispense it. I've seen that in a few cases of that, but by law, they can dispense this. Oh, you not behind the counter? Okay, yeah, so there you go. Yeah, so there's some cases there. Again, I'm going to a whole lot of CVS's, so. Okay, yeah, so in that case, then you wouldn't need the ID. So again, it's nice that even more ready access to it for the patients that need it, right? So that's good. Anyway, so what we're using here, though, are going to be it's a progesterone-only product, right? So again, typically we're going to give a very large dose of levonorgestrel. That's going to be plan B. There are other ones you could use as well. You can use estrogens here. This is probably the most common one that you run into. It's going to be the levonorgestrel, right? And again, usually it's going to be a one-time sort of pill that you take, and then that will allow for basically to kind of help to shut down the process of implantation from occurring. And again, when do you want to take this typically? Oh yeah, so the sooner the better, right? Is always going to be the big thing here. It's not like, oh yeah, last week. Maybe I should think about. No, it's like it's too late at that point, right? So usually within 72 hours, it'll be 99% effective, not 100%, but 99%.
So if that's the case, it's more than 72 hours. Let's say for day 4, so it's not going to be this. It's going to be Ella or because we had that question in OBs.
Okay.
So if it's more than 3 days, do we take Ella?
Which one's Ella?
It's a cholesterol or something.
I have to double check on that one, but and I just mentioned this one because this tends to be the most common one that you end up running into. But you have to double check on that. Olprostol. I'm familiar. I need to double check on that one. Well, there you go. Again, sometimes you find your textbooks don't update as quickly as you would like them to. You know, the usual turnaround time for something that is discovered in the literature before it becomes part of common practice. 17 years in some cases, right? So stuff goes slow. Medicine goes slow here, right? So again, I apologize for not being completely up to date. But anyway, so again, typically the other big thing you have to note here as well, there's a high incidence of nausea, vomiting associated with this, right? So again, if you had a patient who you know needed this, it might not be a bad idea to give them a co-prescription for Zofran, right? A couple pills of Zofran may be helpful here, because again, if you throw up a pill within an hour, you typically need to retake it, right? If you're already nauseous to begin with, maybe all that prone to want to take it again, right? They say, oh, I got nauseous the first time, I threw it up. I get nauseous again the second time, right? So you sometimes get that anticipatory nausea, vomiting. So again, some Zofran may help out with that. Okay. There are other options as well, but again, this is probably one of the more common ones you may run into. Okay, so some other beneficial effects of using hormonal contraception: you have reduced risk of things like ovarian cysts, cancer, etc. Acne can be improved in some patients. Hirsutism may be improved in some patients, depending on what progesterone they're receiving, obviously. These are things to consider. Also think about things like iron deficiency. What do you think that would be helped with these?
No bleeding.
If you're reducing the total amount of bleeding they're having there, that can be a helpful thing. Also note, if you look at that contraception chart, some of those actually include iron along with it, right? So if you see an FE on it, that means there's iron included with it. So that's something to note there as well. That's also important for things like prenatal vitamins, to know if they're getting their iron from that source. They probably don't need a contraceptive that has iron in it, right? Because again, you can't get iron overloaded, because our body can take it in from the diet fairly well, but we don't have a really good means of excreting it all that well. I guess that's one thing to know with that one. So typically for most patients, you're going to start with a combination pill, right? And you're going to use the lowest effective estrogen dose you can. So usually 30 to 50 micrograms is pretty common for the most part. And again, you're going to get a feel for it when you're dealing with these patients. You'll find that, hey, I use this for 9 times out of 10 for my patients, and they do fine with it. I always have a 2 or 3 backups, right? So you can kind of switch over to if you have a good reason to. And find out what their acceptable side effect profile is going to be. Let them know what the normal side effect profile should look like, and then give them a 3-month supply. Say it's going to take a few cycles, and we'll see how you respond to it. If you do well by the end of 3 months, then we'll go ahead and give you the rest of the year with pills there, and you're good to go. Okay. Now, normally, when do you start an oral contraceptive? On a Sunday. Why do we start on a Sunday? Is there anything magical about a Sunday?
No, because the doctor that I worked for, she said men created this, and so they thought that women didn't want their period on the weekends, you know, to have like fun.
Are you saying that men don't know best?
What?
I mean,
this is news to me. I'm just kidding. Yes, right. No, but that was the original intent, right? So again, the idea would be that you would have a period-free weekend, right? Because usually the bleeding period is about 5 days or so. So if you took it on Sunday, by the time you hit your withdrawal period, right, when you hit the placebo pills, it'd be on a Monday. So Monday, Tuesday, Wednesday, Thursday, you'd be kind of done, and then Friday, Saturday, you'd be good to go, right? That was the goal. Right now, is everyone's schedule good for the weekends? Not necessarily, right? So there's nothing magical about Sunday. That's just what has been the common practice for a good long time. But again, usually it's older white men who are making decisions about women's health. Is that always a good thing? Not necessarily, right? Anyway, I don't mean to get political, but anyway, so again, that is the common goal there. But talk to your patient, find out like, hey, when do you want to have your period, right? You know, it may be beneficial if they work every single weekend. Like, I don't care, I'm working. Let's do it. Yeah. So you can schedule it out, right? That's the thing. You want to schedule out the withdrawal period. That's the important aspect of it. If it's post-pregnancy, you know, say 3 to 4 weeks post-delivery, they can go ahead and go back on contraceptives. That's effective there. Post-abortion, again, that Sunday, the first Sunday afterwards, you can get them back to the normal cycle as well. Okay, those are things to think about. Again, it's nothing magical about Sunday. Just the common thing most people will end up doing. Now, again, when do you want to use alternative forms of birth control, right? So what are some cases that we need to? Some people think that during the initial cycle, while you're kind of getting used to it, some people think you may need a backup form of contraception. Again, what are the risks of using a backup form? Not a whole lot. So again, it's probably a low risk recommendation to make, probably not a lot of downside. So is there any evidence to show that you absolutely have to? No, but again, what are the downsides? If you missed pills. Now, we'll talk about this, how you can get what you can do for some of these patients here, but typically the lower the doses of the drugs you're using, the less leeway you have for missed pills, right? Because again, you're giving the smallest amount possible to suppress ovarian function. If you listen to any of that, that function can start to come back, right? Versus if I was like slamming with really huge doses, like everything's shut down for a good long time. If I missed a dose, not a big deal. So lower doses, the more risk you're going to see with that, and you want to recommend using a backup form. Antibiotics, again, this is another controversial one. Again, low risk to make the recommendation to use backup, but not everyone's going to get pregnant just because they're on Clinda and they were taking their oral contraceptives and had sex, right? So if you have a missed pill, this is what you usually recommend. If you have just a single missed pill, just take it the same day, right? Just take it as soon as you remember to go for that. No harm, no foul from that standpoint. If you miss 2 pills, then you can actually catch up by taking 2 pills 2 days in a row. Now, what might that increase your risk for? Just nausea, vomiting, right? Just because, again, that can be hard on the stomach. So, again, let them know, hey, maybe spread it out if you need to, but take 2 pills for 2 days in a row, and you should be back on track. If it's 3 or more, at that point, you've had enough of a withdrawal that you maybe start to have some bleeding, and you're worried about that function coming back. So, at that point, probably just go ahead and DC the rest of the pills for that week and just start, again, back on that new Sunday or whatever day you want to start on, okay? So, again, that's typically what you recommend. Again, that the more you miss, the bigger that margin of error is, more likely you are to have return of ovulation. Okay. Now, looking at missed periods, again, if you have, yes, sir.
That's for taking combination, right? What happens if you miss it?
So progesterone, you're probably going to find if you're taking like a mini pill or something like that, that one's going to be more likely to see issues along with that one, right? So that one maybe even, I'd probably recommend probably similar recommendations, but again, just definitely if you miss 3, like you absolutely need to go and just discard the rest of the pack and just kind of start over again. Yeah, for sure. Maybe even with 2, I'd probably make the recommendation if I was dealing with a family member or something like that, like, it's iffy enough, I'm just going to restart it. Now, again, if you're just have one missed period, especially when you're starting up a new product, it doesn't necessarily mean you need to go out and get a pregnancy test. However, what most people are probably going to do anyway, probably go out and get a pregnancy test anyway, so they're probably going to check, but they don't necessarily have to. Certainly after the first missed one, they would want to go ahead and check at that point. And there's some cases here we can also reschedule the menstrual cycle. Again, I thought this was like magic when I first learned about this. You can reschedule the menstrual cycle, right? We call it honeymooning. Why is that? Because you want to go on your honeymoon. You don't want to have your period on your honeymoon, right? So again, it's one of those things where you can actually just skip the placebo pills. If you continue taking active drug until whatever event they want to not have a period for is passed, then they can basically go back, have that placebo week, and restart their cycle again at that point, right? So you can reschedule things a little bit. And again, that makes sense. If you look at some of the products on that table there, you can take, you know, the drugs we're going to be having a period 4 times a year, 1 time a year potentially. So there's no issue with taking active drug for a more prolonged period of time there. Okay, you just won't have that withdrawal bleeding until you actually get to that placebo portion of it. Okay. Now, if you need to stop pills, you know, if you just want to have a rest period, there's no need to like say, you know, titrate off like you would see with like a glucocorticoid or anything like that. You can just stop cold turkey. No big problems with that. And you may find that if you have a desired pregnancy, at least give them 3 kind of normal cycles before they get back to trying to get pregnant. Because again, you may not find they will return to ovulation immediately. So again, don't let them, just let them know that, hey, if you don't get pregnant that first month, it's not a big concern, right? You know, it may take some time for you to get back to a normal ovulation cycle. Okay. Now, if you have any breakthrough bleeding, typically this is why we give the first 3 months initially, is just to kind of see how they're going to respond to it. Generally, it's going to improve as time goes on. Your body gets more used to having the hormones around. However, it's still present after that 3 months. You may find that you need to manipulate the dosing of the different hormonal components there based on when the bleeding is actually occurring. Typically, if the bleeding is happening in the first 2 weeks, it's usually a result of estrogen deficiency. So in those cases, you may want to use a product that has a higher estrogen dose on the early part of the dosing, a couple weeks there. And then if they're having bleeding on the latter portion of the month, this is probably going to be a lack of progestin deficiency. You may want to use something that has a higher progestin dose on the end of there. Okay, so this is typically what you're going to find with breakthrough bleeding. By manipulating the doses in those ways, you can try to get around some of that. Okay, so ask when the bleeding is occurring, and that can give you a clue as to what doses you want to change there. Okay. And again, if you think about it, we were looking at some of the triphasic products there. Remember, they started with low dose estrogen initially and then kind of gradually ramped it up. They're having breakthrough bleeding initially during the first week. Then maybe you want to use something, maybe a biphasic product or a monophasic product with only 1 single dose of estrogen early on. Okay.
So do we wait for 3 months and then do the changes? Or?
Do it on a case-by-case basis, right? There's like, it's kind of having some bleeding, but it's not really that problematic. Like, hey, just say, hey, give it 3 months, see how it's going to respond, right? Because again, 3 months is a long time, right? If it's very severe, if it's kind of more problematic, and they're like, I just don't want to take this anymore, then you can consider switching them over to something else, right? But again, by giving them at least that 3 months to say, well, just kind of stick with it, see how it's going to respond, and then, you know, it may find that by the 2nd or 3rd cycle, they're like, oh, that's great. I love this stuff, right? You just don't want to discontinue it prematurely, and it could be a potentially good product for them. Yeah. And I mentioned the Depo-Provera. Just remember that you can find activity of this suppressing ovulation for 4 to 6 weeks after a 3-month interval, right? So even if you had someone who had history of bipolar disorder, schizophrenia, you put this on them and then say they were lost to follow-up and you couldn't find them to give them another dose, they still have a decent period of time where they're not going to be at risk of getting pregnant due to that shot. However, the negative aspects of that is if you want to get pregnant after you get one of those shots, you're going to have a delayed return to ovulation. It's just something we know with that. And then you can definitely see some irregular bleeding patterns. Amenorrhea is very common with this as well. Now let's look at some of the miscellaneous products here. Here's an example of an intrauterine device called levonorgestrel or Mirena. This one actually lasts for 5 years. And again, so this is going to be implanted by the provider. I guess not implanted, but it's going to be placed by the provider in the uterus in itself, and it's going to be releasing the drug slowly. And again, this is mainly trying to make the environment very inhospitable for implantation to occur, right? Again, changing the mucus, changing the actual tissue itself, so that way implantation is less likely to happen. Yes, ma'am.
What's the difference between the Mirena and the Skyla?
Believe either it's the dose or it's the actual progesterone itself. There's a lot of different products that are out here. I'm not going to cover every single one of them, but just in general, this is kind of the why we use them, how they're used, etc. Right? Actually, yes. Oh, sure.
So I have a friend who had IUD, and the OB GYN never did an ultrasound to make sure it was incorrectly.
Mm-hmm.
So for a year and a half, the arms never went down. So
Mm-hmm.
they were like this the whole time.
Mm.
So like basically she was always in constant pain, because it was like whatever she would do, especially during intercourse, it felt like she was getting stabbed. So finally they took it out and realized that it never went like
Interesting.
It stayed like this the whole time.
Yeah. Not fun.
So always ultrasound after you take it.
Yes, and that's important as well. Yeah, because you can actually find sometimes this will get implanted in the tissue. You can actually find it may actually dislocate itself actually outside of the uterus. You can actually find it actually end up in the abdominal cavity. It's a rare side effect, but it's something you can actually see rarely, which is again another good reason why you want the ultrasound. Make sure it's right where it's supposed to be. Yep, for sure. Here's an example of the NuvaRing. Again, this can be placed around the cervix and it's going to leach out that drug over a prolonged period of time. This is one that's going to have 3 weeks in, 1 week out. And again, trying to simulate that normal sort of cyclical pattern there, right? This one also has to be kept refrigerated, so make sure, the pharmacist should tell them this, but again, it's one of those things where, you don't want to leave it on your dash in the car in the middle of July. The drug's not going to be all that effective afterwards, right?
Put it back in the fridge for 1 week?
No. You're going to get a new ring, right? No. So typically you get like a box that have like several rings in it, and so yeah. Sorry. Because it just keeps the product stable, right? So because again, when you place it, it's going to be in a 98.6 degree, but that's where how it's designed to work, right? So it's designed to leach out drug at that temperature. Yeah, no problem. Yeah, but if you put it on, it's like 110 degrees in your car, it's going to melt that plastic probably pretty easily.
So if they forget to remove it, would it still be like the Contraindications type thing?
Yeah, you could probably replace it with a new one right away. Yeah, I hadn't thought about that. That is probably what you'd end up doing in those cases there. Yeah, for sure. So I take it out, plop it in the fridge, and come back and work. Not super hygienic. Reduce, reuse, and recycle is always the thing. Because again, in all seriousness, the drug levels will be low enough it wouldn't really be all that effective anymore. I'm sorry?
I just want to say about the IUD.
Yeah.
You got to tell your patients to fill the strings every month to make sure that it didn't migrate.
Yep.
And just in case you guys didn't know.
Yeah, because that means and some patients are going to want that thing removed, and so if you can't find the strings, it's going to be difficult to do.
You have to tell them to fill them every month, just make sure they're still there. And they're not, you have to tell them to go back to the doctor to check, and then maybe get an ultrasound to make sure.
Great education point. Yep. Great education point.
So question for the back row here.
Sure.
How does the NuvaRing go in? Does it give you like a device to fit in?
No. You just basically you can squeeze the ring down and just place it in and just kind of place it around the cervix, and you're good to go. They're just gonna sit there, yeah. I haven't heard any issues of it necessarily falling out early, but if it does, you can just place it right back in. There's usually no issues there. But yeah, once it kind of gets a good placement, I think most people tend to have it stay.
Well, they normally what they do is they give you, they have you use the paper applicators and then have you use that. That's how they give patients to use the paper applicators for your tampons and put it in there and then put it. So we're trying to figure out how to get it.
They usually have a model.
Yeah, right. That again, all these things you want to educate is a big thing, right? Because again, you don't want someone to try to get this thing and they're like, well, how do I use this when they're at home, right? So again,
if you're a prescriber of it, it usually comes with a model.
Yep. Yeah. So models are very useful. Right? So always keep your pelvis handy.
Yeah.
So you can educate. Anyway, here's an example of one that you can actually implant into the patient underneath the skin. So again, this is another progesterone-only product that will be released. Again, irregular bleeding is going to be a more common thing you see with this. That one's good for every 3 years. Again, this is a little bit more invasive than you would see with something like intrauterine device, because again, it actually has to go in the skin versus just being placed into the uterus there. But it's one option. And this is an example of a copper intrauterine device. And so this is actually interesting because this is not non-hormonal at all, right? You can actually find this is just releasing copper ions locally, and it can actually lead to the kind of similar changes where it makes it very inhospitable to implantation there. And this can actually be used for emergency contraception, like postcoital contraception in some cases there as well. You may see that occasionally. But again, this one's nice because it's changed every 10 years. So again, good long period of action there. Okay.
can the patient remove it themselves or no?
No, they need to go back to the provider to have it removed, right? Because otherwise they can probably cause some trauma there if they're using it effectively. But yeah, so again, it's nice because if they had someone who's like, I really don't want to deal with hormones, or my mom had breast cancer and I'm really concerned about, this is a good option as well by being non-hormonal, right? And again, do people normally need copper in their systems? They do, right? It's actually a trace element, right? So again, this is people need copper anyway. It's important for certain, as a cofactor for a lot of different enzymatic reactions. So it's not like you're putting like lead or something in there, right? It's like completely unnatural. Copper is a normal part of your body makeup anyway, right?
So they're going to have regular cycles.
Nothing to do with estrogen. Yeah, so essentially they're still going to have the same sort of bleeding because it doesn't suppress the HPA axis like you would see with like a progesterone. Yeah.
But it is going to make their bleeding heavier. So it's another thing. So if a woman has a really heavy period and you give her this, it's probably going to make it heavier. So you might not want to give it.
Good point. Education. Thank you. You should come up here and teach this. You're very knowledgeable.
Women's health.
Mm-hmm. That's great. Yeah, that's all very, very good points. Thank you for sharing. No, this is great. Because again, we all have our own specialties, right? So again, this is generally outside of my realm. I still read up on it, but I don't deal with it day in and day out, right? So I don't get to see all the ins and outs of a lot of this stuff, right? So, but anyway, yeah, very good point there. So again, you can see worse and bleeding with that. Anyway, so just real briefly, if you guys don't mind if I just finish this up. Actually, I probably have some time. The Peds Jerry stuff is next time. Yeah, I'll go check the board. Yeah, I'm going to stop now. It's only 7.